to everyone who's going to be seeing this video, congratulations on buying and getting your own copy of Conquering Thyroid with Homeopathy by Dr. Dhanipkar. This is going to be a life-changing book, and it's going to really boost your clinical practice. We're going to start at the start. So the first thing that the book has is why he felt the need for the book. So Dr. Dhanipkar used to practice, means he was practicing, and he was treating a lot of patients, and we had already come quite a long way into treating patients of different disorders, and we used to use the clinical method. We used to use miasms, we used constitutional prescriptions, and everything that he did would come, but then there would still be a certain amount of patients that were not doing well in their thyroid cases. So he took this break, and he went on a break for, I think, a few days, maybe a few weeks or a week or so, and he only studied thyroid. He came up with this book, and he saw that there are lots of small remedies and a lot of small tips written here and there, which were not incorporated into regular clinical practice. So he's compiled them, and then he didn't just compile it. He is one of the most thorough teachers I have seen. He compiled it, then he used it in his clinic for a few years, and then he wrote the book. So whatever is in this book is clinically verified. If there is a USP to this book, it is the fact that you can be sure that this has proved to be an effective remedy in clinical practice. We start with Dr. Borker's forward. Now, in Dr. Borker's forward, see, you'll have the book, so I'm not going to go into the details which you can already read in the book. I will be skimming over it so that you'll get a little hang of how to use the book. So this is not a replication or a duplication of the book. It is my understanding and what are the things that I took from this book, along with what Sir has given. So Dr. Borker, in his forward, he mentions a few things about the basic difference in the techniques which we use in our plan of treatment. So what he's mentioned is something called a plan of treatment. Now, this is something new. Here, if you know, most people, they take a history, okay? They take a history of a patient and say, for example, they see the presenting complaints, the past history, family history, physical generals, mentals of the patient. Then they get a totality. They consider this as the constitutional prescription, and they prescribe it. Now here what Sir does, and what Dr. Borker, Dr. Dhanipkar, and now since I follow them, I do, is we have something called a plan of treatment. Now this means that we don't just give one single remedy all through their life. No, we do give a single remedy at a single point of time, and maybe that medicine will be given, and then we don't give anything for 15 days or 20 days, or we don't give until we see different symptoms crop up. But we do know a certain list of medication which will be needed at some particular junction of their treatment. That is what we call a plan of treatment. Now, when he speaks about this and where we got this thought process from, and what is the validation or the confirmation that this was the way it was practiced by the previous homeopathic clinicians that we have. When I say homeopathic clinicians, I mean Burnett, Clark, Borick, Dr. Samuel Hahnemann, Allens. So these are people who had good running clinics, and what they have seen is what they have shared with us. So he's mentioned about the different authors that we consider as authority in homeopathy. And he confirms the ideology of the book from the source books. So he will tell you where Hahnemann has written about it, where Burnett has written about it. So those things you'll find in the forward. He also mentions something called the CPS timeline. Now, the CPS timeline means cause, pathology, and symptom. Now, you will see this in the later half of the book, that we do take a lot of information about the past history of the patient, and we do look for causes there. Now, for example, if the patient has got thyroid, and we notice that it has come due to injury to the thyroid gland, the remedy is conayum. If the symptoms corroborate, symptom 1, 2, 3, 4, we will think of conayum. And it may not be the constitutional prescription. We may already give a constitutional prescription, but we know that somewhere down the line, we will be giving conayum to this patient. Dr. Tijana Razik has also written a foreword. This, I think, is a good forward for you to confirm that there have been a lot of homeopaths who used to practice constitutional prescriptions, and they have incorporated this book into their present day practice, and they have found results with it. Dr. Sunirmal Sarkar has given us forward. Everyone knows what a great clinician Sir is, and he is our guru, and he has really taught us how to prescribe, how to think, what to observe, and he's taught us how to be a homeopath. Now, he has given his validation for the use of this book, and it stamps the efficacy of this book. Now, Dr. Dhanipkar, then he goes over the location of the thyroid, the embryology, and the histology. We will later correlate this with examination, with ectopic thyroid tissue, and with fine needle aspiration cytology. So what he's teaching here, you can skim over it and go back to it when you start going and learning about the different investigations we're going to do. Okay. Now, then he has talked about the physiology of the thyroid, where he has drawn the hypothalamus, then his anterior pituitary, and then the thyroid gland. The hypothalamus, it gives the thyrotropin releasing hormone, which acts on the anterior pituitary. The anterior pituitary produces TSH, which acts on the thyroid gland and activates the production of T3 and conversion into T4, which again circulates all over the body. And then we have the action of the thyroid on the thyroid tissues. He mentions this. He talks about how the thyroid tissue is formed, what are the things in diet, and he goes into it a little bit here. Then we have the regulation. So again, here he mentions this same thing, and how, like, if the thyroid hormone reduces here, if T3 reduces, sorry, T4 reduces, then there'll be two causes. One is if there's less iodine, because of which T3, which was supposed to add iodine to it and become T4, if there's deficiency of iodine, or if there is negative feedback from here. So then we will have to think of pituitary causes for TSH. This will stimulate TSH. TSH will again rise. TSH will again stimulate the thyroid gland, and then again T3, T4 are produced. So this particular feedback mechanism of regulation of how T3, T4, they are formed, and then they go in the body, they're used up, then T3 reduces, TSH is stimulated, TSH gets stimulated, it acts on the thyroid gland, and then again it goes like this. So this particular thing we will need to know again when we are studying the investigations of the thyroid. All this Sir has explained in the book very beautifully. He's given other causes of TSH increase. So if TSH has increased due to other causes besides this particular regulation, which the body is supposed to do and could not do, then we have to look at other causes, which is, one of them is old age. Generalized resistance to the thyroid. This can happen if the person has taken too much of the thyroid prescription. So if the thyroid medication that they've taken was too much, and because of that, the body develops a resistance, then the TSH increases, and then they usually either have to increase the thyroid medication or obviously come to us. And again, another cause is systemic illness. So if there is a very long chronic disease or any very major weakening disease in the patient, that systemic illness may also be the cause for increase in the TSH, okay? Now decrease TSH. This again, I'm telling you, is apart from the any deficit in the regulation of the thyroid hormone, okay, the production. So here, if the patient has any hypothalamic disease, okay, if the patient has had a lot of steroids or has a issue with the adrenal glands, then we'll have decreased TSH. Old age, again, makes sense. The thyroid is also growing old. And other non-thyroidal illnesses. Now, after this, he mentioned certain markers, investigations, and their indications. So say, suppose he's mentioned, we already know a little about T3, T4, TSH, okay? Now he's mentioned TPO, which is a cancer marker. Then he's mentioned anti-TPO. So now we know when to check anti-TPO. When will we do it? When there's Graves' disease. But if the patient has got thyroid cancer, we're going to check the TPO levels. Then we have anti-thyroglobulin. When will this raise up? When there is thyroid resistance antibodies. Then we have TSH. Of course, these are very advanced tests. This is if you come to a stage where you're diagnosing your thyroid cases. TSH receptor antibodies. Now he's given a beautiful tip here, which I must share with you all, and I use it a lot in my practice, is that TPO is a very important test to do in females when they have infertility, miscarriage, fetal death, or postpartum thyroid. Okay, so if we are dealing with a case of sterility, TPO is a vital investigative marker. Then he's also discussed other investigations and their indications, like a thyroid scan. Now, remember, I had shared all this with you here when we were discussing what Sir said about embryology and examination. And so thyroid scan can be used for seeing ectopic thyroid tissue. Okay, so a scan will be the diagnostic for ectopic thyroid tissue. Then we have FNAC for seeing if there's a deficit in the histology of the thyroid gland. And location, we will learn how to examine it. Okay. Now he's also gone into details of most of the common disorders that we get in the thyroid. You'll go through the book and see it, but he's listed 10. So there's hypo, hyper, Graves. Then you have goiter, thyroiditis, which is a viral. So we have a viral cause. We have hypo and hyper, which are deficits in regulation of the thyroid. Okay. Then we have the cancers. Then we have the thyroiditis, which becomes chronic. And some other causes he's written. Now he's written causes which cause deficit in TSH, T3, T4, which are not related to the thyroid gland. Okay, so here what we call these as secondary causes. Now secondary causes, please understand, these are very important if you're treating thyroid cases. Secondary causes are causes which we can very easily treat with once we know that these are the causes. One is a pituitary adenoma. Okay. Another thing is anxiety. So anxiety can cause changes in T3, T4, TSH, but they are due to anxiety, not because of a deficit in the thyroid gland. Okay. And you have there's some other signs I've forgotten. Then we also have symptoms of. So Sir has listed symptoms of hyperthyroidism, hypothyroidism. He's mentioned what, and when he's mentioned these symptoms of hyper and hyper, he's talked about it in every. So when say suppose you're taking a regular homeopathic case taking, and you're seeing, okay, this patient has this appetite, this thirst, this sleep, you will understand that in thyroid cases, this might be a symptom of the thyroid and not of the constitution. So these two are superimposing on each other. So a thyroid case will come with increased increased appetite or intolerance to hunger, like your iodine cases. Okay, or you can have decreased appetite, or you can have desire for particular things that are actually needed for thyroid. You can even have sleep disorders due to thyroid. And at the same time, there is a different constitution, right? So we see a superimposed picture. There is a superimposing picture of your thyroid as well as your constitutional. So say suppose I'm a calcareous carp patient coming and I have got thyroid hypothyroidism. Won't I see part of hypothyroidism come into the calcareous carp patient? This particular differentiation, which we do clinically, will help us understand and prescribe it on the clinical basis and also on the constitutional basis. So we'll see increased sweating, which we see in calcarea, right? Decreased sweating. So increased sweating, we should be seeing it in hyperthyroidism. But a calcarea patient is a fat patient, right? So when we are seeing these two things, we will be able to differentiate and understand which part of it is the thyroid gland, which is causing the symptoms, and which is the actual constitution of the patient. All this, once you start reading this book, everything will make sense. Irregular menses in females. So the menses are affected for sure, usually. Then bowel movements. So bowel movements in hypothyroidism, you have constipation. In hyperthyroidism, there's increased frequency of stool and urine. Then we have fine tremors. So there are lots of things. Heat intolerance. Don't we take thermals of a patient? Yes, we do. But heat intolerance is also a picture of hyperthyroidism. So when you're reading this, please try to keep reading and see what are the differentiating factors, which I'm going to ask to a patient and understand, okay, this is the picture of the thyroid in the patient, and this is the constitution of the patient. Does it sound complicated? Once you read the book, it will all clear up. Trust me, it will. You have to read it's one compact book. It's not even 300 grams. It's a very, very concise book. So you will have to read it one or two times. Dr. Dhanipkar has written like Boric. It's written really concise. You have to go through it and understand it every little bit. That's why I'm doing this video. Then Sir's even discussed Graves' disease, and he's written the different symptoms which are particularly of Graves' disease. In that we have the exophthalmos, which you know about, and the skin, which becomes thick, and then there is pitting edema. Okay, and this you usually see in the shin. So where are you going to check for Graves' disease? In the shin of the patient and in the eyes. Hypothyroidism. Now, Sir has mentioned, and this is a beautiful thing, it is life-changing for patients. Hypothyroidism, he has mentioned it in neonates. So in neonates, when a neonate is not detected with hypothyroidism, then they can have symptoms which are similar to cretinism. So you will see kind of decreased mental retardation and physical retardation. What are the few causes? One is maternal causes, and one is pertaining to the baby itself. Now, in maternal causes, if the mother has not had enough iodine deficient diet, that can cause cretinism. Okay, or if the mother had hypothyroidism, which was not treated during pregnancy, that can also cause cretinism. In neonatal causes, there can be complete congenital absence of the thyroid. Congenital absence of the thyroid. Imagine if you get a child who looks like a baraita, or you know that this child looks mentally and physically retarded, okay, and you do one test, the thyroid function test, the TSH or the T3, T4, and you see that you can treat this patient only by giving them iodine supplements and homeopathy. How much of a change will the child have just by the right diagnosis at the right time? Life-changing. And I think that Sir has given us a lot of tips which we can use, and which will give us immense satisfaction in the success of our cases. He's mentioned the neonatal symptoms. signs and symptoms, like we have jaundice, feeding problems, somnolence, means sleeping disorders, constipation, which are symptoms that we'll first see in a neonate. And then we have to think, okay, if all these complaints are coming, we must think of checking the thyroid levels of this child. One thing I'd like to say, that most of the symptoms look like a cretin, delayed milestones, short stature, protruding abdomen, sparse thin hair, delayed dentition, mental retardation. But what will set it apart from a regular Down syndrome child or a cretin will be the broad set eyes. So the eyes will be further apart. Close set eyes, you'll think of cretins from Down syndrome. But then if the problem is with the thyroid, the eyes will be a little further apart. This is Sir's tips. I'm just sharing it with you. It's all there in the book. Then we have primary causes for surgical removal of the gland. He's mentioned every possible cause. And when we read this, our clinical diagnosis and our prescriptions get better because we have a better hang on what's happening. This book cannot be something that you just read once. Please don't do that. It makes more sense the more you read it. So there's also something called radioactive ablation, which they do in Hashimoto's thyroiditis, where they put radioactive iodine into the just a minute. They put radioactive iodine and they kind of radiate the thyroid gland so that it is not hyperactive. And that's how they control Hashimoto's thyroiditis. Then we have other autoimmune conditions like SLE and rheumatoid arthritis, which are also part of thyroiditis.